To auscultate the posterior thorax, begin at the apices and proceed downward, moving systematically from side to side and comparing the sounds in symmetrical areas. Using the diaphragm of the stethoscope, listen to at least one entire breathing cycle at each location. Listen to the duration, pitch, and intensity of the inspiratory and expiratory sounds, decide what type of breath sounds you're hearing, and note any added sounds.
Now this time, breathe deeply through your mouth. Let me know if it is uncomfortable.
During auscultation, have the patient breathe deeply through his mouth. If the patient becomes uncomfortable, allow a rest period. Now let's listen as the examiner auscultates. If you hear bronchial or bronchovesicular breath sounds where they should not be, listen for transmitted voice sounds.
Now I want to say 99, please.
While auscultating the chest, ask the patient to say 99.
99.
Voice sounds that are louder and clearer than normal are called bronchophony.
99.
This time, would you say E?
Then have the patient say E.
E.
When E sounds like
E.
A and has a nasal quality,
E.
egophony is present.
E. E.
This time, would you whisper 1, 2, 3, please?
Finally, ask the patient to whisper 1, 2, 3. When these sounds are louder and clearer than normal, whispered pectoriloquy is present. All these changes in voice sounds suggest the air-filled lung has become airless. To examine the anterior thorax, have the patient lie supine and breathe normally. Observe the condition of the skin and inspect the chest for deformities, asymmetry, and respiratory movement. Next, palpate the chest to locate any areas of tenderness or to assess any lesions or abnormalities.
No.
Now assess respiratory expansion. Place your thumbs along each costal margin with your hands along the lateral rib cage. Raise loose skin folds between your thumbs and ask the patient to take a deep breath. Observe the displacement of your thumbs and feel for the range and symmetry of movement as the patient exhales fully. Next, following this pattern, palpate for tactile fremitus. As the patient repeats 99, use the ball of your hand to compare symmetrical areas.
99.
Because fremitus is difficult to feel through the breast tissue of women, you may need to gently displace the breast. Percuss the anterior thorax in symmetrical areas, proceeding from the supraclavicular area down to the 6th rib or below. Again, compare both sides. Identify your percussion notes and their locations. You should hear resonance over the anterior lung fields. If you want to check the level of the right diaphragm anteriorly, percuss from resonant lung downward to liver dullness. To auscultate the anterior chest, take the same systematic approach you used for percussing the anterior thorax. If necessary, gently displace the patient's breasts to auscultate all important areas. Listen to the duration, pitch, and intensity of the inspiratory and expiratory sounds, decide what type of breath sounds you are hearing, and note any added sounds. If you hear heart sounds near the heart, try to ignore them while you concentrate on the breath sounds. Now let's listen as the examiner auscultates.
Let's say 99 again.
If you hear bronchial or bronchovesicular breath sounds where they should not be, listen for transmitted voice sounds.
99.
To summarize, examination of the thorax and lungs includes a brief survey of the thorax and respiration, inspection, palpation, percussion, and auscultation of the posterior and anterior thorax.